fact, I would like to congratulate the Delhi Gynecologist Forum and WOW India for taking up such a wide and very important nationwide issue on maternal mortality. And I congratulate the team for making such wonderful efforts. Until now, we have learned about the causes and magnitude of maternal mortality. And we have also learned that hemorrhage, a lot has been talked about. It is a very important cause of maternal mortality. And I'll be dealing with placenta accreta, which leads to significant maternal hemorrhage at delivery. And I'll be sharing our experiences in our hospital about the different cases we have been able to manage and how we have become wiser. Normally we know that placenta adheres to the decidua and it separates easily after the delivery. But in certain situations, when there is abnormal placentation, it is attached with the defective decidua and it leads to different conditions. Placenta accreta, where the placenta just adheres to the myometrium. Increta, where it invades the myometrium. And percreta, when it perforates through and through, reaches the serosa and the adjacent organ. Percreta, although rare, but it is a very life-threatening catastrophic event. So everybody should be aware of these possibilities and entities. And it is one of the most common reasons for emergency postpartum hysterectomy. And the incidence of placenta accreta is rising day by day. In 1970s, it was in the tune of 1:7,000. And the last reported incidence which I could find in literature was in 2002, in which one case every 500 deliveries has been reported. So coming to this first case, she was an unbooked patient, 4th gravida. She presented at 26 weeks pregnancy. She was a case of previous cesarean section. She came with complaint of fever and dysuria. The ultrasound done revealed placenta anterior covering os. This patient was taken up for emergency laparotomy because of hematuria, suspecting rupture uterus. And intra-op there was hemoperitoneum of 1 liter. The posterior wall of bladder was adherent to the lower uterine segment and bladder was lying open. The clots were removed and the bleeders present in the posterior bladder wall were clamped. Hysterotomy done and fetus was delivered out. But the surgeon fails to recognize percreta going into bladder and anticipate complications. Tries partial MRP. There was profuse hemorrhage. Hysterectomy done with difficulty by 2 senior consultants. There was still uncontrollable hemorrhage from bladder. Cystectomy done, surgeons called, bilateral internal iliac artery ligation done, intra-op 6 units blood were given, but the patient died in ICU. And the histopath was placenta percreta. So what is important is that we should all have placenta accreta mindedness. That is very important. Placenta percreta, as I have already mentioned, it is a catastrophic event. Placenta percreta induced uterine rupture have been reported as early as 9 and 14 weeks. Usually the cases of percreta, they are associated with placenta previa, and the maternal mortality reported is very high, up to 20%, and even perinatal mortality in such cases is very high. So what could have been done in this case? First and foremost thing that we talk today, since morning we are talking, anticipation and react. We need a multidisciplinary team, gynecologist, urologist, surgeon, and a good blood bank facilities, of course. Then in such a case, if we have beforehand, we are suspecting such a case, pre-operative cystoscopy and placement of ureteric stents may aid in identification of ureters. But what is important, whenever you are putting a cystoscope, never take a biopsy. The patient may start pouring profusely. And another thing is, one can go for placement of catheters pre-op in both internal iliac arteries. And in such a case of percreta, when you are suspecting bladder involvement, do hysterectomy by posterior approach. Open the uterus segments posteriorly, resect the vagina, and then coming entirely, take out the involved portion of the bladder that is resected with a hysterectomy specimen. Second patient, she was previous to cesarean. She came at 34 weeks of gestation in gynae casualty with bleeding per vagina for 2 days. Ultrasound done revealed placenta anterior low-lying covering os. With informed written consent for possibility of hysterectomy and arranging adequate blood, patient was shifted to OT for emergency cesarean section. Intra of the lower uterine segment was thinned out. Placenta did not separate from lower uterine segment after delivery of baby. Bleeding started. The surgeon was wise enough. He had the placenta accreta mindedness. He had already prepared the patient, arranged for the blood, taken the consent for hysterectomy. He was quick enough to take the decision of hysterectomy. It was done, hysterectomy was done, 3 units of blood given, post-op was uneventful, and the histopath was placenta accreta. So this is very important. Have we become wiser? Now in our institute, everybody is geared up. We have standard operating protocols for management of placenta accreta. And this is a case where pre-operative diagnosis was made. This patient's second gravida with almost 36 weeks pregnancy. She was admitted in antenatal ward in view of placenta previa with anemia. She was a case of previous cesarean section, and on ultrasound, placenta was anterior low-lying covering os. After admission, her ultrasound was done, which revealed the picture of extensive placental lakes, which is one of the findings suggestive of placenta accreta. So her MRI was done, which revealed myometrium was grossly thinned out, but possibility of placenta accreta could not be ruled out on MRI. She was taken up for elective cesarean at 37 weeks. The lower uterine segment was distended. There was increased vascularity with purplish hue with boggy feeling suggestive of placenta accreta. Classical cesarean was done. Baby was delivered out. Placenta did not separate. As the team was well prepared and geared up, subtotal hysterectomy was done. This I will be discussing by subtotal. The bleeding from stump was still present. Bilateral internal iliac artery ligation was done. Paxils given. Post-op was uneventful and the histopath was placenta accreta. So, it is very important for all of us that in all the cases we have seen, the major risk factor is placenta previa with history of cesarean section. But other risk factors which have to be kept in mind are previous uterine surgery, history of previous DLC, myomectomy, Asherman's or a subaqueous leiomyoma, etc. One very important thing which I want to point it out, this is a very nice study by Silver et al. In 2006, in which they have reported that with increasing incidence of cesarean section, there is increasing incidence of placenta accreta, and especially when it is associated with placenta previa. But in their study, they have also reported that in case of previous cesarean section, even if there is no placenta previa, in 0.03% there can be placenta accreta. So this possibility is to be kept in mind. And this patient, I would like to tell you, this we have recently handled. This patient, she was second gravida, previous cesarean. She came to us in emergency with acute pain, abdomen in shock. The team our team was very much geared up. The senior obstetrician was called, blood bank arrangement was made, consent for hysterectomy, patient was taken inside OT. And see the picture, the placenta was funneled and perforating through and through. It was placenta accreta. Unfortunately, since now our team is geared up, we were able to save this patient. So the diagnosis, one should be alert. We have the modalities of ultrasound, color Doppler and MRI. In ultrasound, especially in a patient of previous cesarean, from 20 weeks onwards, we should start localizing, especially in patients of previous cesarean, the location of placenta, and we should follow these patients closely. And if we see more teachings with this appearance of placenta, we find increased placental lakes, or whenever there is obliteration of clear space between placenta and uterine wall, these are the features suggestive of accreta. The sensitivity of ultrasound is good enough, 93%. And if we put the color flows, we get such a high velocity and turbulent flow. In such cases, we should suspect placenta accreta. And one important thing I want to point it out, that MRI is no more sensitive than ultrasound for diagnosing placenta accreta. So it's to be used as an adjunct when there is strong clinical suspicion. And a woman who has previous cesarean and she is diagnosed to have a placenta previa or especially anterior placenta overlying the old scar at 32 weeks, she should be managed as a case of placenta accreta, and accordingly the preparations should be made. Now the AICOT has come up with the latest recommendations that in such a case, elective delivery by cesarean section should be planned at 34-35 weeks of gestation for suspected cases, so that you avoid prematurity as well as the emergency complications. So what are the lessons learned? Prenatal imaging for placental locations, especially in cases of previous cesarean section. Rule out morbidly adherent placenta and previous cesarean with placenta previa. Counsel these patients so they are mentally prepared when they are coming to you regularly. Consent for hysterectomy, arrange sufficient blood and component therapy. You should have seen their consultant, obstetrician, allergic surgeons. And whenever you are operating, never pull placenta. The patient will start bleeding profusely. One should resort to hysterectomy sooner rather than later. And whenever you are planning the uterine incision, it should be made vertically and above the placental insertion site. So these are the important messages. And once you have handled such patients, be cautious about the post-op period. These patients, they have a very hectic post-op periods and they can land up with different complications, transfusion reactions, DIC, we have already learned, sepsis, ARDS, and if bladder or ureter involvement is there can be problems. If you have time, can we go for uterus preserving modalities? Nothing, little about the uterus preserving modalities. These uterus preserving modalities should be considered only in selected patients if they have infertility, because I have gone through different studies and the mortality reported with the conservative modalities has been reported to the tune of 4%. It's very high whenever you are leaving the placenta and managing the patient conservatively. So decision making in such patients is very crucial. You can go for expectant management, leave the placenta, close and then follow up the patients. And if you have the facility of the interventional radiology team, you can go for balloon catheterization and embolization of pelvic vessels. The role of methotrexate still controversial, and uterus preserving surgeries, they should be avoided as far as possible, because if you, the mortality is very high, the patient is bleeding and you are trying the surgeries and closing. So one has to be careful. A word about balloon catheterization or selective arterial embolization. In this you need consultation with interventional team. Pre-op, the catheters are placed in internal iliac artery, and after delivery of the baby, the balloons are inflated to achieve temporary hemostasis. And the advantages are, of course, you are avoiding the hysterectomy, there is reduced blood loss, but the disadvantages are iliac artery thrombosis, maybe sometimes uterine necrosis, sepsis, multiple organ dysfunction. Methotrexate role is still controversial. And expectant management has been reported in few cases in which the placenta was left in situ and the uterus involuted spontaneously and women returned with normal cycle. But what is important is follow-up of patients in which you are keeping on expectant management. You need regular ultrasound, SCG titers, watch for infections, bleeding and coagulation profile. Thank you.
Thank you, Dr. Leena. It was really an eye-opener. So I'm going to